Thank you very much for having me there. Thanks a lot for the invitation. It's an honor to be speaking in front of you today. So what I'm going to cover today is a little bit of an overview of treatment of schizophrenia, putting it a little bit in context of the progress made over the past several decades. This is my conflict of interest. Okay, so the starting point of the talk is that in the last 7 decades, there has been an evolution of the drugs that are available to treat schizophrenia. So clozapine was the first drug approved in used to treat patients with schizophrenia in 1952. Since then, there have been several, obviously many other antipsychotics have come to the market. Long-acting injectables have been marketed as well. The FDA approved in 1989 the use of clozapine for treatment-resistant schizophrenia, and second generations came along later on. And over time, we've seen how pharmacological treatments have been integrated more and more with a more biopsychosocial approach with psychological and social interventions as well. And now we are evolving in the direction of using biomarkers for treatment decision and drug discovery. So despite all of this progress, the reality is that we are still using the same known mechanism for drugs treating schizophrenia. And what's most concerning is that over this time, we have not made a tremendous progress in affecting the outcomes of schizophrenia. Here you can see a first plot of a meta-analysis that was conducted about a decade ago, looking at the incidence of recovery in schizophrenia. And it found that by and large, it was about 15%, which is very low. And what's most concerning is that over the previous 5 decades, the rates of recovery had not changed. So there has been obviously a lot of effort put into developing new and better treatments, but they are not yet having an effect in the lives of most patients. This is what motivated the NIH to invest in the development of early intervention services, which had already been developed, but the aim here was in particular to prove that they were effective in the real world, that under the normal payment mechanism, the normal incentives, they would actually improve the lives of individuals, young patients living with schizophrenia. So that was at the beginning of the 2010s. NIMH put together this very ambitious project, which was called RACE. And this is the paper that summarizes the result of that initial study that was led by Dr. Kane, also at Hillside Hospital, which is where I work. So what they did was to test coordinated specialty care, which is a form of early intervention services for psychosis. And I feel funny talking about this to Australians, because Australians have been really pioneers in developing early intervention services. But I want to tell the story of how it came along in the US. So here, the intervention that was being studied in the RACE study was named coordinated specialty care. And essentially, it consisted on evidence-based psychopharmacology, individual resiliency training, shared decision-making, and supported education and employment. Some of the principles of the psychopharmacological management was the prioritization of second-generation antipsychotics over first-generation antipsychotics, the early use of long-acting injectables in individuals with early-phase psychosis, to aim for symptom reduction, for recovery rather than symptom reduction, to use antipsychotics that have a more favorable side effect profile, to use low doses, and to be very careful about the management of side effects, and also the use of clozapine early on when indicated. So this was a cluster randomized trial, which means that instead of randomizing patients, what was randomized were sites across the US. This is a map of the US that has the sites that participated in the RACE study. And essentially, there were 17 sites allocated to two different interventions. One was called Navigate, which was essentially the CSC package, the early intervention services for individuals with early phase psychosis. And the other one was treatment as usual. And essentially what they found was that early intervention services were effective under a reimbursement mechanism that was very similar to what could be done in a sustainable way, using the incentives that would be available if this was implemented. So here to the left, what you can see are some panels that show in yellow some measures of adherence to the CSC principles for the Navigate, the intervention group. In green are some of the adherence to some of these principles of early intervention services for treatment as usual groups. And to the right, what you can see are the changes in symptoms and function. The main outcome in this study was functioning, and the secondary outcome was symptom reduction. For both outcomes, CSC was effective. The day after the results were made public, the investigators and NIH went to Congress here in the US, and they requested the allocation of funding for this type of services to make them sustainable under the incentive system. And actually, they were able to achieve that. So the Congress put aside money that is used to support the implementation of CSC, of early intervention services, the same way that they were studied in the RACE study originally by clinics in the community. So clinics have grants available so that they can implement early intervention services in a sustainable way. The investigators went on to study whether the outcomes were sustained over time. The intervention was prolonged for 5 years, and here are the analyses for the entire follow-up of 5 years. 2 findings. One, individuals with early phase psychosis disengage very much, and we are going to come back to this. This is, in my opinion, a very important, a very serious problem. And here, what happened was that the attrition rate was very, very high, which complicated the analyses. The other finding that they have is that 5 years after the initial randomization, CSC, the early intervention services for schizophrenia, were still effective in both reduction of symptoms and improvement of function. So this was quite compelling, putting this in context of other countries that have done that and other research done in this direction. The findings are very consistent. This is a meta-analysis that was conducted comparing treatment as usual versus early intervention services all over the world. The finding was that for all of the outcomes included, early intervention services was advantageous over treatment as usual. So the evidence is very compelling that this type of psychosocial interventions in which the psychopharmacological management is embedded is actually very favorable for individuals with schizophrenia. Now, one of the outcomes that was not looked at in RACE or in the meta-analysis I just cited is mortality. So we know that individuals with schizophrenia have premature mortality to the extent that they live between 15 and 20 years less than people who don't have illness. This is an important population health problem. And the reasons why people with schizophrenia live less are very multifactorial, but one component is that particularly early in the phase of illness, individuals with schizophrenia are vulnerable to suicide. So this is an opportunity. Early intervention programs have an opportunity to reduce mortality through that mechanism, through intervening when the rates of suicide are the largest. And these are data that come from an early intervention service in Ontario in Canada. What they found was that individuals, looking at population records, individuals that had been treated with early intervention services actually had much less mortality, to the extent of 4-fold less than people that were treated with treatment as usual. These are not randomized data, but still it's a very large effect size. It is aligned with the other outcomes that I showed before, and this goes to say that there are many reasons why early intervention services should be the norm for the treatment of individuals with schizophrenia, and that's the way it's here in the U.S. There are many incentives for clinics to follow to deliver this type of treatment. Now, one question is what happens after the early intervention services stop? At one point, people that enter this programs are going to age out, and they typically go back to treatment as usual. So what happens with that transition? These are data from the OPUS study in Denmark, in which the early intervention services went on for 2 years. And here the investigators looked at the outcomes in terms of mortality and function and symptoms over 2 decades. And what they found was that actually the effects dissipated over time, and that over 2 decades, it was indistinguishable who received early intervention services early on and who didn't. The conclusion I take from this, and by the way, this has been looked at in meta-analyses looking other studies, and the conclusion holds that early intervention services are very effective. However, after they are discontinued, they lose that effectiveness. And to me, what this shows is that schizophrenia is an illness that is very complex. It's multifactorial. Treatment requires multiple fronts, and that probably is necessary for the entirety of the illness and not just the early phase. Now, the problem also, I mean, I mentioned incentives, and incentives are going to dictate what really happens in the real world. It may be a great idea, but if there's no money, or if the psychiatrist has reasons to do otherwise, the treatment is not going to be early intervention services or CSC, or however we want to call it. Here, what we did was to look at the adherence of to CSC principles in people that were treated with for an early phase psychosis in Missouri. What we found was that the adherence to some of these principles was uneven. For example, the integration of psychopharmacology with psychotherapy was very rare. The monitoring of substance use in people with early phase psychosis was very low. And that's one of the recommendations that in race, actually, the use of drugs was over 50% in people with early phase psychosis. So it's very important to monitor addictions in this population. However, in our survey, we found that very few patients actually had evidence of that type of screening. So this goes to say that I think that the evidence for CSC, early intervention services, is very compelling. However, it's important that the incentives are actually aligned with this type of treatment, so that actually patients can really get it in the real world. And now, I mentioned before that disengagement is a large problem. To me, this is something that I think is not getting probably as much attention as it should, and it's the fact that how do people with early phase psychosis use treatment? So we looked at this question in the entire population of Finland. We looked at the first episode population in Finland. We followed them up for over 10 years. And the question was, how do they use treatment? How long does it take for them to be disengaged, to stop taking any medication? And what we found was that people with schizophrenia are going to use treatment intermittently. So they'll use it for some time, they discontinue, use it for some time, they discontinue, and so forth. And what happens is that this, in the early phase of treatment, they are going to be very likely to disengage, and then they're going to come back, they'll stay for a little bit longer and disengage again, and so forth. So it seems as if patients were learning the hard way that they should stay on treatment and that they should not be disengaged. The problem is that, as I will cover in a little bit, some of this discontinuations or going back on medication is the result of a relapse, and sometimes there are irreversible losses with relapses. So learning the hard way after several relapses may mean that these people are losing the ability to respond to treatment, and they may be experiencing some irreversible losses. We also studied what was the effect of different drugs in time to discontinuation, and we found very interestingly that LAIs were within individual analyses were much more likely to be used for longer periods of time compared to other antipsychotics, to the extent that when we were comparing for each given individual the time that they were on the oral and the time that they were on the LAI, the hazard ratio was the average hazard ratio was 0.3, which means that there's about 70% greater longer time to discontinuation for people that are on the LAI. Now, what about, so I spoke about disengagement. It's very common. People learn the hard way. What about when people are in treatment? Well, at that moment, we know that adherence rates are very low. And this is not just in schizophrenia. We know that in general, in chronic illnesses, the adherence with medications tends to be very variable. It's very difficult to measure. And these are, I think, that very interesting evidence that show how difficult it is to ascertain the degree of adherence with medications. This is a study that we did in our hospital. We had 100 consecutive admissions for acute psychosis, and we got a plasma level of antipsychotic for that person. And we asked the doctor, do you think this person is acutely is adherent or not? And you would imagine that that's a moment where you really need to know whether someone is adherent or not, because if they are non-adherent, you're going to probably resume the antipsychotic they were on. If they were adherent, you may consider maybe switching to clozapine, if that's appropriate. So it's very relevant, and we want to think that we are good, and still we didn't get it right. Most often we were wrong. We tend to overestimate adherence. When we think that someone is adherent, we may be right, but by and large, the conclusion from this is that it's very difficult to predict who is adherent and who's not adherent, and we should assume that everybody's going to be non-adherent and that we won't be able to tell it. In our study, what we found was that the majority of people actually were not adherent, as you can see on the pie chart to the right. So how to approach the issue of non-adherence? Well, we know that about half of our patients are going to be non-adherent with treatment. The problem is that we don't know which half. Therefore, it's very important to normalize non-adherence. It happens in schizophrenia, happens in diabetes, happens in COPD, happens in many medical conditions. It happens to patients, happen to doctors as when they are patients, when we are patients. So I think it's very important that we normalize non-adherent. Doesn't mean that the doctor is doing anything wrong, doesn't mean the patient is doing anything wrong. It's just human nature. And we should set that framework to have a frank conversation with the patient and tell them that we know that you are going to be non-adherent at some point, and that we need to be ready, and you need to be informed about what are the consequences of non-adherence, what are some of the risks, so that you can act accordingly. And to me, one of the reasons why it's important to have this conversation is that non-adherence is the first reason why individuals will show relapses, and some of the losses that happen with relapse are irreversible. To me, these are some of the more elegant data to make the case for this. These are data from 130 patients that were treated in Toronto for a first episode of psychosis with a standardized treatment with risperidone. They were followed up, and they were again treated after they had experienced a relapse due to non-adherence. So what you can see in the clear green are the response rates defined as a 50% improvement in symptoms after the first episode. And what you can see is that there's an early, and it starts picking up early, and people actually get to very, very high rates of treatment response. Now, when patients were treated for a second time, then the rates of response were much lower, which comes to say that in many cases, they are losing their ability to get as much benefit from treatment as they did on the first time. So some of the things that we can do for our patients is, in addition to have a frank conversation, is to propose strategies that we know prevent relapses. And the most effective intervention is our long-acting injectables. This is very uncontroversial. Long-acting injectables are superior to oral drugs preventing relapse. This has been demonstrated using different approaches like randomized controlled trials, cohort studies, pre and post studies. These are data from a meta-analysis that was conducted by our group. And regardless of the approach that was used, what was reported was that there was a benefit for LAIs in any case. So it's very uncontested that LAIs are better. One reason why we hear that they are not used more often, and I am not very familiar with the situation in Australia. I can talk more about the situation in the US, where the rate of utilization is about 15%. So here doctors very frequently will say, well, young patients don't want to be on long-acting injectables. They don't like needles. And we know that that's not exactly the case. These are data from the pre-relapse study, which was a study led by John Kane, in which what they did was to train staff to have that conversation that I just mentioned, normalize non-adherence, and propose the LAI as an intervention that has demonstrated to reduce the rates of relapse. And what they achieved was a rate of taking at least one long-acting injectable treatment for over 80% of those individuals that were approached. So this goes to say that long-acting injectables are actually, when presented appropriately, most patients don't have an issue with it. However, I think that in early phase patients, this is tricky. Long-acting injectables are thought, at least in the US, and I think that that's true in most places, they are thought as an intervention for people who have already demonstrated non-adherence. The problem is that that's too late. As I mentioned before, if you're learning the hard way, if you are getting on treatment for longer periods of time after having experienced multiple relapses, you may have had some irreversible losses. So yes, it may make sense to have an LAI in those patients, but it would have been more beneficial if that LAI was used early on. Unfortunately, that's not the case. I mentioned that the rate of utilization of injectables in the US is about 15%. In the case of early phase patients, it's about 4%. We run an epidemiological survey using data from payers. And what we found was that for early phase patients, not just there is a very low rate of utilization of long-acting injectables, but if you're looking at the predictors to initiate a long-acting injectable, and that's what this chart represents, what we found was that the only thing that predicts if you're going to start a long-acting injectable in an early phase patient is if things have already gone wrong. Well, that's too late. You need to be proactive about this. You need to treat relapses prophylactically rather than acting after the fact. However, people still may relapse despite long-acting injectables. So it should be part of the psychoeducation that patients receive, that it's going to be less likely that you have a relapse, but it's not, it cannot be guaranteed that you won't relapse. And here we looked at this particular issue. We studied relapse in individuals that were treated with long-acting injectables for whom non-adherence is not a confounding factor. Here we know that all of these patients were treated with long-acting injectables with therapeutic doses, and we followed them up. Here in the chart, what you can see for each line is the incidence rate, the cumulative incidence for one given randomized controlled trial of a long-acting injectable. So here we are taking only the individuals that were taking the long-acting injectable. We followed them up over time, and what we found, we were measuring the cumulative incidence of relapses over time, and what we found was that it happened in about 20 events per 100 subject years. If you have 100 people that you treat with long-acting injectables for a year, about 20 of them will have a relapse despite being on injectables. So It's not a small number. The factors that were most likely predicting relapse were residual symptoms, tardive dyskinesia, and substance use. I also mentioned clozapine. So clozapine, I think that in Australia you may be using it more than what we use in the US. It's obviously very important to treat treatment resistance, and this should be a conversation that starts also early on. And I think the justification for that is that in most cases, treatment resistance is going to start from the get-go. On the paper that you have on the left, these are data coming from England in which the investigators followed people with an early phase psychosis over a decade. They characterized treatment resistance, and they characterized the timing of it. What they found was that among those that met the criteria for TRS, over 80% of them met the criteria from the get-go. So it's already something that should be discussed in the early phase. Now, to the right, what I am showing you are recent data of the delay of the use of clozapine. So these are data from Taiwan, in which what they found was those patients that were started on clozapine, they had an average of 6 failed trials. So I mentioned before, these are many relapses, and this is a prolongation of the time that someone is acutely ill. And what they also report here is that the longer the delay, the worse the outcome. So here goes to say that it's very important to have that conversation about residual symptoms or treatment resistance from the very beginning of treatment. Something else that is probably insufficiently addressed is our substance use comorbidities. So to the left, you can see a panel that shows a forest plot of the incidence of substance use disorders in people with schizophrenia, and they show a pooled incidence of about 50%, which is very high. So it is very common. There are no treatments that are specialized in this population, which again is a big chunk of those that are living with schizophrenia. There are very few studies. One of them was the BRIGHT study, which is a study that Janssen did several years ago, in which they looked at the use of long-acting injectables for individuals that had a criminal history. And here, what I am showing on the first panel are the relapse rates of people that were treated with long-acting injectables versus orals. There were some advantages of the long-acting injectable among those who had a comorbidity of substance use. And the second panel are those who did not have a comorbidity of substance use. LAIs were advantageous in both situations, much more advantageous in patients that didn't have a comorbidity. So it's very important that we develop better treatments for this population, which is again a big chunk of those living with schizophrenia, and for whom there are important limitations in the type of treatments that we have available for them. So to end the first part of this talk, how can we best capitalize on the existing resources? These are all things that are accessible to us that we could use with patients. And in my opinion, there are solutions coming at 3 levels. One is the healthcare system. So again, going back to the incentives, are they aligned so that individuals can really receive coordinated specialty care treatment? So that we see that there has been some improvement in terms of the type of funding that the clinics can get, at least here in the US, to deliver this type of care. But still, probably more needs to be done, as we showed in that review, that the adherence is still not yet as good as it could be. Principles should probably be extended. Principles of ESI should probably be extended beyond the 5 years. We should address treatment disengagement. The system should accommodate for this problem, and I think that probably Australia is ahead of the game compared to the US in terms of how to manage this. It's important to attend to addiction, medical comorbidities, and to take a special emphasis on the decreased life expectancy for this population. and also real-time quality of care feedback. I think that that's very important. That's something that we are piloting in our hospital, which is to give very specific feedback for a given patient. So for a clinician. So we will tell the clinician, this person is due for their hemoglobin A1C, this person is on 2 antipsychotics, this person is on a long-acting injectable, has been still reporting symptoms for a year, you should try clozapine. So these are things that the system can do to facilitate the adherence to evidence-based practices in the care of people with schizophrenia. At the prescriber level, I think that we should revisit some of the care that we deliver with special emphasis on long-acting injectables and clozapine, which are highly underutilized in this population. We should reconsider the discussions about adherence. We should train people to have that discussion, how to talk about long-acting injectables, how to talk about clozapine. And then I think that the data from the early intervention services literature shows that involving the families is crucial. It's very important to guarantee that there are good outcomes. So I think that that's something that cannot be ignored, and the family should be involved in with high quality psychoeducation, and they should be part of treatment, obviously. Now, that was with things that are already accessible, and that for which the most important thing is just to align incentives so that they can get to the clinic. Now, what about things that we could do in the future? And obviously, there are several things like developing better drugs. I'm going to talk about precision medicine, for which the principle is more about, at least in what I'm going to talk about, how to personalize the current treatment to any given individual. So broadly speaking, biomarkers can be of different nature. They can be genetic, they can be of fMRI, resting state fMRI, they could be of structural MRI, PET, spectroscopy, etc. And they could have several applications. They could be applied to predict who is going to transition from at-risk mental state to full-blown psychosis. It could be used to predict who's going to respond to treatment. It could predict who's going to respond to clozapine, who's going to relapse after treatment discontinuation. These are all applications of current strategies, but personalized based on information that we would have about the particular risks for any given individual. Now, the development of biomarkers could be compared to the development of drugs, in which there are several steps that need to happen in a sequential order. So the first thing is to identify a target. So the first thing is to be able to obtain a biological measure that is related to the clinical outcome of interest. For example, in the case of treatment response in schizophrenia, over the years, the research has been very clear that striatal function is critical to the response of clinical response to antipsychotics. So that would be an example of a target identification, somewhere to go after, something to go after for biomarker development. The next phase is internal validation and external validation, validation in general. Internal validation refers to making sure that the effect you're showing in, for example, classifying responders from non-responders is not related to a confounding. For example, in the case of fMRI, motion is a very common confounder. So making sure that you're not having a biomarker of motion. So, having a biomarker that, in addition to whatever presence you have of a confounding, you still detect an effect. So that's internal validation. External validation means that your result is generalizable, that you're not finding the results only in the sample that you use to develop your biomarker, but that if you use it in an unknown, in a person that's unknown to the development model, it'll work, so that it can be really applied in the clinic. And then the last step is to demonstrate clinical utility. Are you improving outcomes in people that are receiving treatment informed by biomarkers? If I use a biomarker score to define whether someone's going to be on clozapine as the first drug, does that change outcomes in any way? So that's really the litmus test of biomarker-based care. We recently conducted a review of the state of the field in terms of biomarker development, and in doing that systematic review, we highlighted a couple. And this couple of biomarkers They were both resting state fMRI measures. So just for those who are not familiar with resting state fMRI, what it means is that individuals will go in an MRI scanner and they are scanned for something between 5 and 15 minutes most often. And what we do is to take the activity, we measure the activity at each voxel of the brain over time. So we have essentially a movie of activity over time. And then we look at the activity in 2 voxels, and we will see if they are going up and down together in terms of activity. We will say that they are functionally connected. If they are firing at asynchronous rates, they are not connected. So that's the basic principle of some of the analyses that these biomarkers do of resting state fMRI signal. And the interest has been on the striatum. The reason for this is that the striatum is the location of the brain in the brain where most of the D2 receptors are located, and that's the target of antipsychotic drugs. So I'm going to highlight the FSA, the functional striatal abnormalities. This was a biomarker that was developed 3 years ago by mostly a Chinese group, but there was input from Australian and British investigators. And essentially here, what the investigators did was to train to use a machine learning algorithm to train that model to distinguish between cases and controls, people with schizophrenia, people without schizophrenia, based on fMRI data. They use several inputs of fMRI data, and using very sophisticated methods, they actually found that with a quite rigorous testing, the classification was about 80% correct. 80% of the times, approximately, the machine could, just looking at the fMRI signal, they could classify whether someone was a patient under control. And most importantly, because I don't think that diagnostic use is really going to change practice, because we might as well talk to the patient. But importantly, they reported that people who were that the biomarker score actually correlated with treatment response, and that could be applicable. If we are able to predict treatment response, then we can actually determine whether someone might benefit from clozapine as a first drug that they are treated with after a diagnosis. We went on to replicate some of this biomarker findings, and we actually found that the diagnostic properties that I mentioned actually are replicable in a completely different data set with actually quite different population and conditions. It worked very well. It had substantial discrimination between patients and controls. However, the biomarker score did not predict treatment response. So our conclusion is that the biomarker was trained on a case control model, and it does that very well. It predicts treatment versus controls very well, but it was not trained in a model that used treatment response to train the algorithm. So that's why we think it didn't work. But this is promising, because this suggests that with the appropriate sample size and paradigm, using these advanced statistical approaches could actually lead to the development of valid biomarkers of treatment response, which could be applicable in the clinic. The other biomarker that was developed was the SCI, the Striatal Connectivity Index. And very briefly, I will just summarize that what the SCI does is to take the functional connectivity of several connections between the striatum and other regions in the brain, and it selects functional connections that we know are predictive of treatment response. And this was developed in a cohort in our hospital, and then it was tested in a different cohort, completely independent, and it showed an area under the curve of almost 80%, showing that again it's very it can be actually quite accurate predicting who's going to respond to treatment and who is not going to respond to treatment. We recently replicated this in a third data set, completely independent. Here we found that the area under the curve was 0.72. So again, this is very promising biomarker. Still, there's work to do with it, but we think that this could be very helpful in the clinic, because if we can tell that someone is going to not respond to a first-line drug, we could consider then to use clozapine as a first option for these patients. So just to summarize what comes next for biomarker development, I think that still we need to obtain biomarkers that are developed with larger sample sizes. We need to develop them with clinical paradigms that align better to the uses that we will have in the clinic. For instance, we should not be using a case control paradigm to train a treatment response model. We should treat the treatment response model to train a treatment response biomarker. We should still do some additional testing of the validity. We should replicate more the findings that we obtain in this initial passes of biomarker development. We should try them in clinical trials. We should demonstrate that biomarker-based care is actually superior to treatment as usual. That if we decide to start clozapine as the first drug for a given individual based on the biomarker, that's going to lead to better outcomes. And obviously, as I showed before, clozapine and long-acting injectables are already available and underutilized. So we need to learn lessons from the implementation of these drugs whenever we are rolling out biomarker-based care in people with schizophrenia. So just to end, I think that this is my last slide. So we should optimize currently available resources, optimize clozapine, long-acting injectables. We should be proactive about relapse prevention. We should pay attention to non-adherence and disengagement. We should treat adherence, addiction and medical needs. We should advocate for system-level reform while taking still individual responsibility for the things that we can do to optimize treatments. And we hopefully will see in the future the biomarker, hopefully some positive results for biomarker development. And obviously, we still need to develop drugs that are more effective in many domains of the illness that still we don't have good treatments for, like preventing conversion to psychosis, cognition, negative symptoms, etc.